Welcome to Hi Rasmus and Friends, Stories Behind the Science, hosted by Hi Rasmus, the leading clinical platform for ABA therapy. Each episode highlights inspiring stories from experts and individuals with unique perspectives. Join us as we explore valuable insights and foster empowerment within the autism community. Hello, and welcome back to Hi Rasmus and Friends. I'm your host, Amy Cook, and today we're diving into the story behind whole child impact in autism care. Joining me is Dr. Stephen Merahn, a physician and systems innovator shaping integrated models of care, and Dr. Breanne Hartley, a leader in the applied behavioral analysis field and passionate about advancing clinical excellence in family-centered practice. Thank you both for being here today. How are you doing?
We're good.
Doing well.
Thanks for having us.
Thank
Good.
you.
Awesome. Well, let's get started and we'll kind of dive right in. We'll start with Dr. Hartley. If you can tell us a little bit more about your background and how you got into the field and what you're doing today.
Absolutely. So, my journey into applied behavior analysis started about 25 years ago. That's when I really just stumbled upon the work, and it was in my undergraduate experience. I had majored in psychology, but I didn't quite know what population I wanted to work
Mhm.
with at the time. So, I was dabbling with a couple of different internships and working with different populations, had worked with the geriatric population, had worked with individuals who were experiencing substance abuse, and that was all really fantastic work, but it wasn't really like kind of lighting my fire.
Mhm.
What started to light my fire is when I had stumbled upon an autism practicum within my undergraduate university. And what I quickly realized is that autism practicum was implementing applied behavior analysis strategies. I had one, never heard of autism, and two, had never heard of applied behavior analysis. So all of it was new to me. I was a complete novice in so many different ways, but I had a wonderful advisor who leaned into me and saw that I was really enjoying the work that I was doing. And again, this was all my undergraduate work, and she had suggested I go to this thing called graduate school, which that was a complete novel concept to me. My family doesn't have a long history in higher education and whatnot, so graduate school was really not on my radar at all. But she had pointed me in the direction of Western Michigan University, and that's where I obtained my PhD in psychology with an expertise in behavior analysis and got to study under amazing professionals there, and always continue to look back very fondly on those experiences and feel extremely lucky to have had the training that I did. But essentially, from there, have dedicated my professional career to working with children on the autism spectrum, really diving into ways that I can make an impact, not only in the individual work that I'm doing, but to the field at large. So now, fast forward 20,
Yeah.
25 years later, really feel passionate about making an impact. So, of course, we're going to talk a lot about the work that UNIFI is doing and whole child care. That's the theme that you had identified. But I'll just comment that another area that I'm extremely passionate about is that giving back to the profession, that kind of
Mhm.
service. And so I've been on the board for the Behavior Analyst
Yeah.
Certification Board for a number of years, currently serving as the president of the board. And that really has given me the opportunity to help guide the future of this profession, help guide what is required in terms of maintaining and obtaining certification, which I'm very enthusiastic to be a part of.
Awesome. Thank you so much for sharing all that. I want to hear a lot more about Unify, and I know we're going to get there. But I think it's also would be really interesting for especially our BCBAs to hear about kind of how you got into um, interested and kind of what your career, I guess, professional development looked like with the BACB. So, you humbly say that you are now you are on the board of directors and now you get to be the president. But especially a new BCBA, they might be like, well, how did that happen? How, that might just seem so far out there.
Hmm.
So tell us about, I guess, some of your early work together with the BACB.
Sure. Well, and I can absolutely say that girl that I was telling you about so many years ago that said, "What's graduate school?" Definitely didn't have it on my radar whatsoever that I would have any opportunity to collaborate with the BACB. It certainly wasn't on my radar to be the board president. But what initially allowed me to begin contributing to the work that the BACB does is, oh gosh, probably about 15-ish years ago or so, I had a colleague reach out to me who was helping the BACB through some of the ethics work that they were doing. They had established an ethics committee of sorts that would help certificants be coached through kind of ethical scenarios that they were finding themselves in as practicing behavior analysts. And so I was volunteering my time with the BACB to be an ethics coach for them. And so I would be assigned cases for behavior analysts kind of out in the world who were finding themselves in ethical conundrums. And I was helping coach them through the experiences that they had. And at that time, I had probably a good 10 to 12 years of certification under my belt. And so I was a bit in a mentorship role in that capacity. And so I had done that for probably about 8 years or so with the BACB. And then that allowed me to contact some opportunities as a subject matter expert for the
Very
BACB.
cool.
For listeners who aren't
Hmm.
familiar with that role, the BACB is always continually looking for folks to join them as subject
Hmm.
matter experts. There's an application process. You can go to the website and learn more about that. But that's a really good opportunity to serve your profession and give back and become involved. And it opens up different opportunities for networking with other professionals across the country. So I had engaged in subject matter expert work for quite a long time. And then that had allowed me to contact work with the BACB, but it was still not on my radar in terms of board involvement. Uh, it was in 2022 that the BACB was looking for an additional board member, and I had a colleague of mine nominate me for that opening. And so it was something that really came to me. And until then, I really didn't have that as something that I was pursuing
Good.
necessarily. But when that opportunity arose, it really allowed me to think about, yeah, that makes sense. That's an
Hmm.
additional way to level up in terms of my contributions.
I love that. Well, thank you so much for all the contributions you've made. And Dr. Stephen Moran, I got the pleasure of kind of hearing about your journey, but I know our listeners and viewers have not, and you
Sure.
have a very unique story to share also. So let us know kind of how you transitioned from the medical field to autism care, and then also kind of how your paths crossed with Dr. Hartley also.
Sure. Well, first of all, if I were to tell the whole story, we'd be here for another 2 hours. So I'll pick a couple of
Yeah.
high points. I would say that it wasn't so much a transition from the medical field to something else. I had an experience very early in my career where I was the only doctor among a group of other child-oriented professionals. I was the medical director for the Bureau of Daycare for the New York City Health Department. And unlike most physicians who work around other physicians, it was really an opportunity where I was the minority discipline in it among some very, very deeply experienced early childhood educators. These people had all been either center directors or in leadership roles similar to roles that Breanne just described, but in the early childhood community. And I became kind of fascinated with how interdisciplinary or interprofessional collaboration worked.
Mhm.
And what happened to me was I was drawn into the early childhood community even more than I was drawn into the pediatric community. I was going to the National Association of Education Young Children Conference. I belonged to an organization called 0 to 3. I kind of immersed myself in that world because I was part of that community. It wasn't that other people were part of my community.
Hmm.
And I would say, if anything has kind of set the tone for my career since then, that experience was really the thing that made it very easy for me as I started to work with children with disabilities. And in the pediatric community, the autism subcommittee of the American Academy of Pediatrics is part of the Council of Children with Disabilities. And there's a tremendous community in the pediatric community that focuses on autism particularly, but also medically complex or disabled children overall. And I had actually been the chief medical officer for a national primary care practice taking care of homebound elderly. Now, I know that sounds odd for a pediatrician, but as you said in my introduction, that my role there was about systems design, not about being a geriatrician. I had geriatricians on either side of me who were more than happy to help set the clinical policies and programs that were relevant, but my job was to transform this medical practice from a fee-for-service practice into a value-based care practice, and all of the systems operational elements attached to that. Uh, After completing that task successfully, I really wanted to get back towards taking care of children.
Mm-hmm.
And I had an opportunity to join a large ABA provider as their first and only pediatric chief medical officer. And the thinking was that behavior analysts share the care of children with autism with the pediatric community, and we should be able to build bridges into that world. Well, it turns out, to be quite honest, that was hard to do in this particular organization, which was really focused on ABA as their primary focus. And I was there for 4 years. It was an amazing experience. I'm very grateful that I was able to have that. But it was actually the thing that introduced me to the behavior analytic community. I went to CASP, for example, in 2016, when it was a tiny little group of people. And I felt so welcome, similar, by the way, to the way I felt welcomed by the early childhood community, and really felt like there was an opportunity, as Breanne said, for me to share the pediatric perspective on these children that we shared the care with. And that was really the beginning of that process. And in 2019, I actually founded a nonprofit organization which was entirely focused on the idea of behavioral health integration. Unfortunately, COVID kind of didn't allow my vision to be fully realized. But as part of that participation in the early childhood community, I was asked by CASP to participate in the original standards committee for what became the Autism Commission on Quality. And one of my fellow committee members happened to be a woman named Breanne Hartley.
Oh, there we go.
I'm busy pontificating on my pediatric perspective at these meetings. And by the way, and Breanne knows this, so I can be blunt about it, which is things I felt the behavior analytic community weren't doing that would be in their best interest. Because I always feel, and I've actually published this in a book, that the behavior analytic community needs to be a much bigger and more prominent part of the broader healthcare ecosystem. Behavior analysis as a science is desperately needed in healthcare across the board. Not, put autism aside, whether it's disability or health-related behaviors, we know that behavioral determinants of health are a prominent cause of positive outcomes. And the science of behavior analysis is an amazing tool to do this, and unfortunately not fully adopted, integrated, or accepted by the healthcare community. So I'm talking this stuff, and the committee was like, well, we're really here to talk about autism and ABA, which I, again, correct. But Breanne reached out to me on the side, and we started to have a series of conversations. She really wanted to learn more. I think we've already learned she's open to exploring those kinds of ideas. And we began to conceptualize a behavior analytic practice that was really focused beyond just autistic symptoms and behavior. And in pediatrics, again, for what we would call medically complex children. Now, on one hand, there's a spectrum of medical complexity. On one hand, it's children who may be technology dependent or have gastrointestinal tubes or require tube feeding or have other kinds of problems. In the middle, there's children perhaps with intellectual and developmental disabilities, and on the other end of the spectrum are children for whom their condition is chronic. It causes functional deficits. They need a lot of family support, and they see a lot of doctors. So it's that, and I consider many children with autism to be part of that, not necessarily because they have deficits, but also sometimes just because of the way society treats them or accepts them or affirms their distinctive needs. But the fact is they often need special supports and families need special supports. So we began this conversation and said, how can we actually create a behavior analytic practice that incorporates some of those? And that was really the beginning. It was before UNIFI was even called UNIFI, which, by the way, was Breanne's brilliant naming convention during a brainstorm session. Uh, but it's the idea that children, period, whether they're autistic or not, um, all have we all want to aspire for optimal life course outcomes for children, period.
Absolutely.
Disabled, not disabled, neurotypical, neurodiverse, doesn't really matter. And how can we begin to use the science of behavior analysis to support autistic children on that life course path? And that's fundamentally what we talk about when we talk about the care model at UNIFI. Um, I'm, uh, I'm, and I've told this story a million times, having looked at, no exaggeration, hundreds of behavior analytic plans in some of my roles. I very, very rarely, if ever, saw a goal for supporting medication adherence
Mm-hmm.
in an autistic child's behavior plan. Now, why is that important? Well, 50% of children with autism are on some kind of chronic medication. And it is, even though the medication itself may not be in the scope of practice of a behavior analyst, the behavior of taking medication is well within the scope of practice. And if you can help a child with seizures, allergies, asthma, gastrointestinal conditions, all of which are common co-occurring conditions, who are on a medication, reduce the burden of their health problem, that's a positive whole child goal. And that's kind of where we net it out in the development of the model.
Absolutely. Awesome. Well, I do want to take kind of one step back. I want to hear about kind of your unique backgrounds and how you shaped the care model at UNIFI. But just in case anyone doesn't know, Dr. Hartley, would you want to share a little bit more about what services UNIFI provides, where you guys are located, and then you can kind of get into how you feel like your unique backgrounds kind of come together to shape the care model as well.
Sure, absolutely. So UNIFI is currently throughout the state of Indiana. So we have several locations throughout and across the state. And primarily, the services that we provide are largely a summation of what Dr. Merahn just identified. We're providing applied behavior analysis treatment implemented and supervised by a BCBA partnered with a registered behavior technician, and kind of all of the ways that organizations across the country are accustomed to seeing. But we are very much leveling up on what that all consists of. So I would imagine that's a lot more of what we'll continue to dig into through this conversation as you talk about whole child care, and how we're sharing the care with professionals like Dr. Merahn with a pediatric background and whatnot. It allows for the evolution of behavior analysis in some really unique ways. And so, to maybe get to your question associated to maybe our unique backgrounds, it was great for Dr. Merahn to identify how he and I met through being
Mm-hmm.
on the standards committee for the Autism Commission on Quality. And I feel so fortunate, one, for Steve to, and I to have collided, our worlds had collided. But for me, it was happening at a perfect time, because I feel like when you ask about, my unique kind of skill set or thought process and whatnot with all of this, is the timing that I had the opportunity to meet Steve was occurring when I had been a practicing behavior analyst for almost 20 years at that point, and was seeing a lot of behavior analysis done in complete isolation of what other healthcare professionals were doing. And as Dr. Merahn is talking through the medical complexity of children on the autism spectrum, I found myself growing, I guess, increasingly frustrated with the
Mm-hmm.
fact that BCBAs are on their island and other healthcare professionals are on their islands. And broadly speaking, this is an overgeneralization, but broadly speaking, behavior analysts aren't so inclined to collaborate with other professionals. And so I guess maybe in retrospect, I'm realizing the uniqueness associated to my perspective when somebody like Dr. Merahn is communicating with largely a group of behavior analysts, and for me to have reached out to say, like, what you're saying is very interesting. I suppose not every behavior analyst would catch that or identify that what he was saying, what he was advocating for was so significantly needed within the work that behavior analysts were doing. So it was really the timing of all of that happening and our worlds colliding was perfect for me because it further helped plant a seed that we as behavior analysts need to do things differently. So I feel like in a way, the uniqueness that I bring to UNIFI and the work that we're doing is the open-mindedness associated to behavior analysts have a great baseline level of knowledge and expertise, and we're better together with other professionals.
Absolutely. Well, thank you so much for sharing that. I want to kind of dive more into whole child care, but we might throw that term around a lot, but it might mean different things to different people. So,
Very much so.
yes. So, Dr. Merahn, if you want to share, what does whole child impact mean to you?
Well, I'm gonna let's just talk about how we define whole child to begin with, because
Okay.
that's really how we have to look at it. So one of the things that I noticed about the behavior analytic community is that often the the targets for intervention were grounded in its own vocabulary, or
Mhm.
as I saw very often, sometimes the targets for intervention were actually grounded in the categorical framework of an assessment.
Mhm.
So we do an assessment, we identify some challenges in the assessment, and we use the language of the assessment to begin to target. And as I'm fond of saying, I want my child to mand, said no parent ever. So, and it's not that mand is a bad word. It's that we there's like other people don't understand.
Mhm.
It's a distinctive language. So one of the things that Breanne and I and the team talked a lot about was, is there another way to categorize our assessment process and use the tools and the insights from assessments in a slightly different way? And we ultimately landed on a set of child-centered domains, some of which are known to be associated with the diagnostic criteria for autism, communication, social interaction, but some of them are not.
Mhm.
And because they are, in fact, child-centered domains, they're the same developmental domains that all children go through. And because we know that there are, as the health example being a perfect one, sometimes there are reverberations from a challenge in a domain that reverberate to others. So, for example, um, you know, managing transitions can also affect behavior, community behavior. I mean, there's so we decided to look at it from that perspective, and instead of targeting the I hate this word, but targeting the deficit, or
Mhm.
identifying the place where there could be some skills growth, probably a better term than deficit. um, we decided to put these in the context of these developmental domains and do the analysis and set goals that are focused on the developmental domain. So, what developmental domain? Expressive communication,
Mhm.
right? Expressive, and there's lots of ways to categorize expressive communication. And in fact, manding is nested in that umbrella, that developmental domain of expressive communication. Um, so that's one of the ways that we began to evolve this process of looking at autistic children in terms of their wholeness, not just their autism. Breanne, you want to add to that?
I think it's the ad being that again, emphasizing how behavior analysts can look beyond maybe their primary training and their
Mhm.
primary expertise and lean into what does healthcare look at, because Dr. Marin, what you identified as developmental domains. And so we as behavior analysts can't lose sight of, typically speaking, not always, but behavior analysts who work with the autism population are working with the pediatric population, maybe not necessarily the adult population. So there's a lot of development that's happening. And so making sure that we're looking at the child as a person, as a whole person. You asked about, okay, well, how would we define whole child care? Like really looking at the whole child and not just their autism symptoms.
Yeah, the other thing that we do regularly as part of the assessment process is we actually reach out to other professionals who are sharing the care with this child, and we ask them specifically, are there behavioral determinants of the realm you're working on, neurologist? Are there behavioral determinants of the realm you're working on, gastroenterologist? Are there behavioral determinants of health that you're working on, primary care pediatrician, where we can contribute to your care plan? And
Awesome.
we've got, I mean, quite remarkable success engaging the medical community. And that's not the only realm, but I'm giving that as an example. Engaging the medical community to say they're now setting the care plan. The behavior analyst is orchestrating care plan goals, but they're not setting every single goal themselves.
And what a great way to build that rapport, get that trust and buy-in, and be able to collaborate to have the best outcomes for the child, by reaching out to the others. So that goes right into kind of my next topic was going to be, if we're looking at whole child, then we also need to look at shared plans of care. And so you just kind of touched on that, but what do you think organizations often overlook when building shared plans of care? And I guess I'll start by saying, I think most behavior analysts, there's an emphasis on parent training, and, it being family focused, but I think it goes beyond that. And like you just shared. So, yeah, I guess share a little bit about what you might think some other organizations might be overlooking.
I just two quick points, and then I want Breanne to comment here. Uh, there are a number of principles that are well accepted in healthcare that that it would do the behavior analytic community really well to adopt.
Mm-hmm.
One of them is the concept of shared decision making. Now, that's easy to say, oh, well, we do that, but in fact, there's a discipline behind it. There's a definition for it. And one of the places that we in medicine use that is with people who are medically complex. Because, by the way, if you were to follow evidence-based guidelines for all 8 of their conditions, first of all, there'd be no time in the day. You'd only be doing healthcare stuff. And at some point, you need to prioritize one issue over another. And shared decision making allows you to work with parents and get their input as to whether the goals that you have set as a professional align with their needs.
Mm-hmm.
And sometimes, by the way, you may say, I want to do these goals because I consider this to be really important. And the parents are like, you know what? I really only want to do 3 of those.
Mm-hmm.
And they're going to prioritize those 3. And that's not a loss. And there's no ethical issue in that. That is, in fact, a legitimate approach to care that would do really well to be adopted. We always, every parent that we work with goes through an interview that looks at hopes and dreams and wishes and aspirations. And those actually become the basis of a much bigger plan for that child.
Mm-hmm.
Because we're able, and I'm getting into Breanne's space here, but
That's great. Yeah.
A broad-based, high-level aspiration may actually have to be brought down to something as simple as, well, before we hit that big goal, we really need them to respond to their name, right?
Mm-hmm.
But then there's a connection between the respond to the name goal and that broader parental goal, and you've got a much higher level of acceptance and commitment now to those what may not look to be significant goals, but as they ladder up, you're going to get to that bigger goal with the parents. The second piece is the issue of shared plans of care is not unique to behavior analysis and pediatrics.
Mm-hmm.
It's an overarching problem in the healthcare system as a whole. Each discipline, cardiology, neurology, gastroenterology, feels as if they have the autonomy to create their care plan, the neurology care plan, the gastroenterology care plan, the rheumatology care plan, and it's often difficult to integrate those care plans into one set of goals that each of those disciplines can support.
Absolutely.
Yeah, beautifully said. The only thing I'll add there is I love how it was emphasized in terms of the family or the caregiver's input. You asked, overarching question being what's oftentimes overlooked in terms of these
Mm-hmm.
shared care plans. And unfortunately, I do think that the families can be overlooked as a significant contributor to the goals that are identified for their child or their loved one. And the adaptability piece too for behavior analysts, because as Dr. Merahn had identified within our processes, right as we're starting treatment for a child, we're learning a ton from the family in terms of what their goals and aspirations and what's going well, what's not going well. But we need to identify that maybe a month later, some things change, or 6 months later, some things change in terms of the family dynamics and what priorities are kind of shifting. So we need to be very adaptable in the way that we're programming for goals that are identified, and not just applicable to being the family's adaptability, but the physician, maybe the pediatrician that the child sees, 3 months ago had certain priorities and then those are adjusting. So I guess the continued collaboration and communication amongst all of the shared care, proponents. So a behavior analyst isn't necessarily thinking, okay, well, I started services with this child. I kind of checked with everybody, crossed that off the list. Like I am now doing shared care and I have, an integrated treatment plan.
Mm-hmm.
It's an ongoing process.
I love that.
Yeah,
I'd like to
yeah.
hear more from both of you about which outcomes or measures matter most at UNIFI. And I'm wondering now if some of that's going to go back to the family. But we also talked a little bit about the assessment. So yeah, share a little bit about measuring outcomes and what that looks
Well,
like.
I want to follow up one thing
Yeah.
about the shared plans of care. Um, there's a lot of conversation about determination of medical necessity and service intensity that's been taking place,
Oh, yeah.
and and there is I will admit for a very long time I was a big fan of the dosing analogy for ABA.
Okay.
There was an aspect of that that made sense to me, um, but it's not entirely analogous. A dose of ABA is different than a dose of a pharmacologic
Mm-hmm.
compound. Um, the pharmacologic compound is known to have a certain efficacy at dose,
Mm-hmm.
whereas the dosing of ABA, or the intense service intensity of ABA, is distributed among multiple goals. And the fact of the matter is, and this is, again, has to do with the idea of back to shared decision making,
Mm-hmm.
you may, as a professional, determine that certain things are medically necessary, but that doesn't necessarily mean that they're necessary to the family. And while it is true that if I had a child with type 1 diabetes and the parents determined that the medication was not necessary, that would be subject to some outside opinions. It is not the same
Mm-hmm.
for behaviors. There's a much longer treatment time that you have with children from a developmental perspective, and therefore there is an opportunity to shift some of those medically necessary goals into another time frame.
Mm-hmm.
Uh, Now, you ask about outcomes. This ties to the outcomes
Yes.
question. Actually, triggered it
Yes.
because it ties to the outcomes question. So, and I'll be blunt about this. There is a tremendous difference between response to treatment and an outcome. And this is where things often get conflated. Again, not just in the behavior analytics space, but in other aspects of child development. Uh, Response to treatment is a very legitimate approach to measurement-based care,
Mm-hmm.
MBC, by the way, in the psychiatric space, in the in the substance abuse space, MBC, measurement-based care. There's a whole body of literature on measurement-based care. Again, I urge behavior analysis to look outside their literature because there are lots of analogous things going on in other disciplines. And I'll give one story and then I'll let Breanne comment here, which is if you have a child who scores a 2 out of 10 on a social skills assessment, and your intervention over a 6 or 12-month period moves them from a 2 to an 8 on their social skills assessment, that's not an outcome. That's response to treatment. How the child uses their social skills improvement in real life is the outcome. So, and again, that's harder to measure, but I really would love to make sure the word is right, because I know we're going to talk about value-based care in a few minutes, and that's where this becomes really important.
Well, it comes back to changing lives. I mean, you've got to see it.
So, it's a very different assessment in terms of what an outcome is, as opposed to response to treatment. And we differentiate this in medicine. And I think there's a real importance among behavior analysts to begin to understand that difference.
Dr. Hartley,
in regard to that example with scoring a 2 versus an 8 on a social skills measure, for example, really what that comes down to in the ways that we're looking at outcomes and measuring outcomes at UNIFI is, is the family and is the child really working towards a higher quality of life? And, all of that needs to be assessed through all the processes that we had identified when we're beginning treatment for a child. And so, for us, it's really looking at looking beyond short-term skill acquisition to ask ourselves as clinicians things like, is this child gaining independence? Are they able to participate more fully in their school, with their family, in their community? Are we reducing stress for the family and improving their confidence as caregivers? And so, we do measure traditional clinical indicators, skill progress, reduction of various different barriers, quote unquote, challenging behaviors. We're looking at treatment fidelity. But really what matters most are the outcomes that extend into adulthood. So we're typically treating, the pediatric population, but children become adults. And so we need to make sure that we're very mindful of what does progress and what do effective outcomes mean into adulthood.
I love that.
So two add-ons to that. One is part of that is ensuring the maintenance and respect for the child, the strengths the child walks in with, and ensuring that the interventions are not going to necessarily interfere with what might be a very powerful portfolio of strengths that may be grounded in their neurodiversity. So we have to be really careful not to undo things about them in the quest for some of the skills goals that we may set for children. Breanne talked a little bit about the consideration of this child's developmental trajectory into young adulthood. And this also becomes really important. There's again, I'm gonna keep encouraging the behavior analytic community to look outside their discipline, because there is a robust body of knowledge and assessment tools in what are called patient-reported outcome measures, PROMs. And there are PROM assessments that are very, very, very well accepted and validated in other disciplines that behavior analysts could adopt. And in doing so, you're now using the same measures that are used in other fields. And that actually validates the work you're doing by saying, we're not going to use an ABA assessment. We're not going to use an autism assessment. We're going to use a child-centered PROM, PROM. And using the child-centered PROM, now we're basically aligning our performance against, or aligning or comparing our performance against other disciplines that use that same measure.
Wonderful. So let's talk a little bit about value-based care and how UNIFI is carving a unique path towards value-based models. And I'll just say, it almost seems like is probably not the best intro to this question, but values-based care has almost become a buzzword in our field. But does everybody really know what that means and what that looks like? So I'd love to hear from you, Dr. Hartley, kind of what that means and what that looks like, in particularly at UNIFI.
Mm-hmm. I think we've started to touch on some of these themes, and so now we can aim to put a finer point on all of this. So for Unify specifically, we want to redefine what value actually means in autism care. And so traditionally, reimbursement models in our field have been built around hours of service. So Dr. Merahn was commenting on this earlier as he was identifying, dosage, intensity. Typically, that's synonymous with hours of service. And what we've historically, I think, as a field looked at is quantity over quality. But we know families don't come to us asking for a certain number of therapy hours. They come to us asking for outcomes that matter. And I'm hoping that we've emphasized those points throughout the conversation, assessing families' perspectives, looking at quality of life. And so things that tend to matter for families: independence, communication, community participation. And so what we're working to do is to align our care with those outcomes. And when we do that, it becomes more associated to value in terms of value-based care. So this really means building that whole child model where ABA, medical, family supports are all integrated, and then we're measuring success not by the volume of therapy provided, but by real life progress that children and families are making. So our unique path is about shifting from that more hours equals more care to better outcomes equals better value. But I know that Dr. Merahn can bring a lot of interesting insight from outside of the behavior analyst analytic community.
Well, as I mentioned early on, I was the chief medical officer of an accountable care organization, and have subsequently worked in many other population health value-based care programs and contracts. The problem that everybody faces right now is the anchor for most value-based care is economic value. We talk about it from the perspective of patient quality, and it's true. Reducing hospitalization rates in people who use the hospital is good for them, but at the end of the day, the compensation associated with that goal is economic. It's shared savings or some type of capacity to more carefully manage the economic resources that are allocated to children. So a very important differentiation I want to make here, which is any type of capitated program is not value-based care. Really important to understand that. Capitation is not value-based care. Capitation is value for the payer, but there's really very little involved in capitation being value-based care. No, I'm not saying there's anything wrong with capitation. It's a great business model for certain programs, but it's not really value-based care. The idea of, here's a great example. If an ABA provider could in fact reduce emergency room use, children with autism use emergency rooms 4 to 6 times more than neurotypical population. If you could make a deal with a payer to say, we're going to actually contribute to the reduction in emergency room use, we want half of the money that would have been spent last year. That's a great value-based contract, a genuine, legitimate value-based contract. We're going to stop ED use. We get half of the savings. That's shared savings program, very legit. What I'd love to see is for the behavioral analytic community to really show, again, the value that they're creating in the system. For example, when children go to kindergarten and need fewer services and supports. That's a value-based contract. And so that's one. Now, there's granted, a lot of controversy over what kindergarten readiness is. And if you go dig into that literature, your head will explode because there's all sorts of differences in terms of what that constitutes. But the fact of the matter is, if I'm able to work with a child for 2 or 3 years, that typically, based upon when I met them, would have required a certain level of services and supports, and I'm able to get them to the fact that that's where. Now, the other issue there is those pots of money are all distributed with different silos. So how do you resolve that? It's by the way, across the board, the behavioral health, and when I say behavioral health, I'm talking about IDD, autism, substance abuse disorders, mental health issues in adults. This is a tremendous problem in that group as a whole. And again, I encourage behavior analysts to join together with some of the other behavioral health providers because everybody's struggling with the same thing. I remember when I first got involved in ABA and the controversy over this thing called medical necessity. How dare people tell? Well, guess what? The medical community has been dealing with it for 50 years. Um, and yet there was no recognition that this was like it was as if this new experience and it was created just for them. So getting out of the niche really becomes critically important for behavior analysis as a discipline and profession to achieve the level of success that honestly I think they deserve.
Awesome. Well, I've got a loaded question for you, Dr. Merahn. And I know we just have a limited amount of time, but I hear one theme. We need to get out of our bubble for sure and learn from others. But if you could redesign the autism care system, what would you prioritize first? There's so many different things. What would you look at first?
The first thing I would do is is this my imagination? I get anything I
Yeah.
want?
Oh
Like,
yeah, you got a
okay,
magic
so
wand.
magic wand, great.
This is dangerous
I would,
now.
I would create uh, behavior analysis departments in every medical school and major academic medical center. And I would bring behavior analysis in as a basic science to the medical community, just by the way, as we do with immunology and genetics. These are basic science departments that everybody gets to learn the basic science and how that basic science may support what they do. So cell biology allows us to understand immunology better, which allows us to treat infections better. Genetics, similarly. I would snap my fingers and make behavior analysis a basic science across the healthcare system, because then you'd have other people thinking about how they can use your science to solve their problems.
Absolutely. Even just implementing treatment plans. You talk about
Right.
children with
Exactly.
autism
Across the
taking their
board.
medication,
Across the
but
board.
yeah, it goes across the board. Okay, well, I'm going to ask Dr. Hartley if you had some advice to give to some emerging leaders in this space. What would you say to them, people that are listening?
Mhm. Yeah, I think really it boils down to never losing sight of the why. Why is it that we're doing what we do, staying grounded in all of that. In autism service provision, it's really easy to get caught up in the metrics, the authorizations, the staffing challenges. There's always going to be barriers for traditionally those leaders within ABA practices, and those barriers can kind of bog you down oftentimes, and you're kind of swimming around, and if you lose sight into why is it that we're doing what we're doing, that can really lead you astray a lot of times. But within the field, having that anchor in terms of identifying, ways to remain compassionate, remain a significant advocate for the children and the families that you're providing services to. That's where it can be very helpful to not lose sight of that why. And then as a leader within a behavior analysis, service organization, oftentimes by nature you'll get pulled further and further away from the work that you fell in love with,
Mhm.
specifically directly interacting with the children, engaging with families, coaching and training staff, things like that. And so it is much easier said than done, but aiming to build in those reinforcers into at least your month, maybe not your week, maybe weekly that can't happen, but monthly, really setting aside some time to, get back into the work that you fell in love with.
I love that. That's great advice. Well, before we get to our closing question, where can listeners go to learn more about UNIFI, whether they are seeking employment or looking for services? I'm sure there's all different listeners listening right now.
That's right. And we'd love to engage with all sorts of listeners, whether it be families looking for services for their children, or to your point, individuals who are looking to join the UNIFI team and be a part of the amazing work that we're
Yes.
doing. Our website is a great resource, unifiautismcare.com. And then we're also quite active on social media between LinkedIn and Facebook and X and whatnot. So we'd love for folks to go there to learn more about us.
I love that. So, our slogan at High Rasmus is focus on the child in front of you. We like to end each episode by asking our guests to think about their own children or the children closest to them and think about how do you focus on the child in front of you. So, I'll start with you, Dr. Merahn, if you want to
Okay.
answer that question.
Actually, I'm glad you did, because Breanne's actually probably trying to keep the children from running onto camera right now. I have 4 children, 2 of whom are adults, and I will tell you that I continue to worry about them to the same extent I did when they were toddlers. I think that's probably the story of my parental life. Right now, we started out talking about my daughter, who's a high school sophomore, and kind of struggling with the fact that she's back in school. So I'm really just trying to be fully present for her. There's a running joke in my family, don't take this phrase wrong, but it's like, I love you, and my daughter would be like, can you just love me a little less? So I am fully present, and often a little more intensely than they want me to be. But as I've learned from the older ones, over time they have come to appreciate it.
Wonderful. And
Yeah.
Dr. Hartley, you want to share?
Sure. Yeah, my life is filled with children. I get to work with children through the work at UNIFI, and I have 4 children of my own. And regardless of if it's my own children or the children I have the opportunity to work with, what I found is that I need to kind of stop and ask myself, how can I support this child right now in a way that is meaningful and empowering to them? With my own children, they vary in age. From my youngest is 5, my oldest is almost 14. So they have vastly different needs, just like the children that we work with at UNIFI. Although they all have autism, they all have vastly different needs. So it's always important to pause and not kind of intervene, either as a mother or as a clinician, in kind of cookie cutter ways, really making sure that we're meeting the child where they are.
Absolutely. That's wonderful. Well, thanks for tuning in to High Rasmus and Friends, and a big thanks to Dr. Stephen Merahn and Dr. Breanne Hartley for sharing their insights on whole child impact, and just such an important conversation for all of us to hear. And I just really appreciate your guys' time and being here. So remember, real impact starts with seeing the whole child in front of you. Until next time, take care. Bye. Thanks for joining us on High Rasmus and Friends, Stories Behind the Science. If you enjoyed this episode, please subscribe to our podcast and leave us a review. Your feedback helps us continue to share inspiring stories and foster empowerment within the autism community. See you next time.